Yeah, we start? Okay. Can we start now? Yeah, okay. Thank you. Nice to be here, and I would thank Dr. Vishali for this opportunity. Let's start with this patient who is a 35-year-old gentleman with blurring of vision in the left eye of 15 days duration. The patient gives a past history of one episode of CSCR in both the eyes previously with spontaneous resolution. So we did the fundus photograph shows a small yellowish spot just adjacent to the fovea in the right eye, and the OCT shows a focal choroidal excavation. I don't think you can see it there, but okay. This is the focal choroidal excavation, which is of the conforming type, and also the patient has a pachychoroid with a thickness of about 405 microns. This is in the right eye, and the patient was symptomatic in the left eye, which shows a vision of 612, and there is a subretinal fluid, and patient also has a pachychoroid. And the fluorescein angiography done, the right eye was unremarkable. The left eye shows ink blot leak, which suggested that it is a central serous retinopathy, which underwent a focal laser treatment. 1 month later, patient presented with blurring of vision now in the right eye with a vision drop to 618. And now one can see that there is hyperreflective area in here with subretinal fluid. And now there was also a hemorrhage. So this, considering that this is a CNV, we did a fluorescein angiography which shows a type 2 CNV. Patient received a bevacizumab, and post-injection, the vision improved to 6.9, and the OCT now shows the reappearance of the focal choroidal excavation. The left eye also shows a resolution after the laser treatment to 6/6. So this is a patient who has the pachychoroid and also has a focal choroidal excavation. So we know about epitheliopathy, vasculopathy, and the neovascularization associated with pachychoroid. Now we have focal choroidal excavation, which is also an association, which I think Dr. Bailey has reported in his paper in 2017 about the frequent association of focal choroidal excavation with pachychoroidopathy. Thank you.
Thank you, Dr. Hemanth. We have another case by Dr. Guha, and then we'll go for the discussion.
Many thanks to Dr. Vishali for having me here. There was some communication gap. I couldn't present in the morning. Thanks for accommodating me. And I also thank Dr. GT sir for going all the way to the preview room to see my slides. So just two quickly, because I know there's a paucity of time. The first case, the patient, 40-year-old woman, with dimness of vision and retinopathy with unremarkable antecedent findings. We had this subretinal fluid with a choroidal excavation. On angiography, you can see a single point leak, which increases the rate phase. So this was a typical conforming type of choroidal excavation which we could find out. This was found out on retrospective analysis. Unfortunately, there was no follow-up of this patient. So just want to point out the difference between dealt with by DT and retinal. That conforming as opposed to the non-conforming on the other side, where there is a split between the photoreceptor and the RP layer, which is more frequently associated with visual symptoms and CSR. The second one, which I thought that we are catching it at the early stage of development, it should be of interest to the more august panel who will discuss it later on, that this was a case of CSR, where we on the right side, if you can see that dip. So as with any lesions, this would also, FCE would also be undergoing a process of the deepening of the cavity, so as to speak. So we might be, and again, this patient is also lost to follow up. It would have been interesting to see how the cup deepens. So without going into, this will be, I think, dealt with when he discusses. There are several associated conditions, like Dr. Murthy mentioned about CSR, which has got the highest percentage of incidence of FCE, 6 to 8%, as in different cities. The CNB, PCB, best bibliform macular dystrophy, as was found out in Jay's paper. And AMD, and recently the Japanese group has also reported association with nudes. So as opposed to the congenital theory, there could be acquired cases of FCE also, as we see in nudes. These are the examples in association with AMD. Post-injection, you would see on the top slide, the FCE persists. The case with macular hole, taken from the literature of course, and an asymptomatic case, incidental finding of an FCE. Thank you to Jay for letting me this slide. There is a case, there were two cases that he reported of breast disease among all the hereditary forms that he had to find out, and this is one of them. And the other, the Japanese group has reported FCE incidence in case of nudes, FCE formed after the resolution of the inflammatory lesions. So, last slide, what's the significance of this FCE? It's important to follow these cases for any new onset of CNV, because the milieu is akin to pathological myopia and angioid streaks, with the RPE, Bruce CCC complex participating in that. So we have to follow this up for a long time to observe changes from non-conforming to conforming, and especially after PDT or anti-VEGF injections. And we have to observe for recurrence of CSR, because they have typical instance of recurrence of CSR over the FCE. And the group has also dealt with measuring the greatest linear dimension of FCE, which they found to be associated with larger GLD to associate with other maculopathologies. And the importance of fellow eye for the following issues. Thank you.
Thanks, Sushant. We'll have now Dinesh for discussing the case, and after Dinesh discusses, there can be 1 minute for any question from the audience.
Good afternoon. I think we have two cases of focal choroidal excavation, both of which were actually non-conforming. Focal choroidal excavation was first described by Jampol in 2006. And in a series of 4,000 scans, it was found to be there in 16, which is a prevalence of 0.36%. The usual GLD is around 600 micron, but those with concurrent macular pathologies have larger lesions. The area of the choroidal excavation usually has a thinner choroid, but the surrounding choroid is usually thicker. Now, the important thing is that there is a relationship of PCV and lacquer cracks to these lesions, and also the association of CNVM, which I think Dr. Freund had described. The main important thing is that as a rule, the conforming focal choroidal excavations are incidentally detected. Most of the patients have good visual acuity and in fact may have a normal looking retina. In fact, in patients who did not have a concurrent macular pathology, half were not even visible clinically. It was an OCT diagnosis. Whereas in the other half, there were some focal RPE abnormalities. And the fact that this is extrafoveal in a majority also ensures that very often it is a missed diagnosis. Now, just to show you the difference between the conforming and the non-conforming is what you see here is a conforming lesion, and basically the photoreceptor tips, the outer retina conforms to the choroidal excavation. That's the important thing. Both the cases which were, this is not my slide, this is a slide from a presentation, from a publication. The lower two, you have non-conforming lesions where the photoreceptors and the outer retina is pulled up. And of course, in both these, there was actually a pathology which was responsible. That means there was you can see there's an ERM in one and there's a scarring in the other. The important thing is now, why does this occur? Actually, if you look at it, there are two types of lesions. There is the congenital posterior segment malformation, which was thought to represent a microstaphyloma. The other one is a secondary lesion, and I think that's what we must concentrate on. Those lesions, and the prerequisite of that lesion is it has to be something which causes a focal choroidal atrophy, whether it's some kind of a choroiditis or a choroidopathy, and it has to leave overlying retinal structures normal. When these two things combine together, that's when you're likely to get a focal choroidal excavation, and that kind of focal choroidal excavation is secondary. This is a patient whom I saw, and if you see in February, this patient came with a CSR. But when she came later, you can see a choroidal excavation forming over here in July. And you can see this started in March, it started forming, July it became more, and now it's become deeper. So there has been an evolution into the form of a choroidal excavation starting from CSR. So this is a very clear-cut evolution occurring. So this is the second pathology, the secondary ones. Basically, the excavation extent is best evaluated by near-infrared autofluorescence, which I don't have a slide of. But the important thing is we need to be aware of this condition because often it's an incidental finding. It could be secondary to a pathology, a choroidal pathology. And the CNVM, when it occurs, is usually a classic CNVM which responds very well to anti-VEGF treatment. Therefore, if you see a patient who's got a choroidal excavation, at least follow him regularly. Change from a conforming to a non-conforming pattern also suggests that maybe there is now either traction occurring or maybe the RPE atrophy is now likely to cause some kind of a secondary pathology. Thank you very much.
Thanks, Dinesh.
Yeah.
And,
Can we have a comment from...
Bailey is getting up. How rare is this rare pathology?
Yes. I told you, it was found in 16 OCTs out of 4,400. So that's something like 0.36%.
I just want to make a comment because unfortunately sometimes I think I don't get things completely right the first time, and with newer imaging we learn more about a specific entity. But one of the things I think I should have realized, there was a disproportionate number of patients in our series of young myopic women. And what was peculiar is that they often had thick choroids. There have been a number of reported cases that other people picked up and sent to me, and I've seen, where you can get these choroidal excavations in punctate interchoroidopathy or multifocal choroiditis. Some of the cases you showed had some features of that, sometimes overlapping with central serous. So what happens is, when there's inflammation, these patients get these inflammatory pigment epithelial detachments. They look like just a drusen. And if it's sort of mild inflammation, it doesn't cause a punched out scar, those lesions can come and go. And what you can see is that when the RP and Brooks membrane splits, the Brooks membrane becomes defective. You see dehiscences in it. And then when the inflammation subsides, the retina sinks down. And so I think a number of the patients we reported probably had these episodes of inflammatory PED. We completely missed them. They didn't have symptoms, but then you follow them long enough, and then they have a recurrence. You're, oh, this came from that. So I don't know what proportion.
Actually, I went through your paper, and what actually I believe is, it is the first thing to occur is some kind of a pathology in that area.
Yeah.
That pathology, that's what I said, the prerequisites have to be two. It should not affect the retina. If it affects the retina, then what you get is retinal atrophy above it.
Exactly.
So it shouldn't affect the retina, and only the localized choroid should get affected. So lacunar cracks is another cause, because that's a localized area where the weakening occurs.
And you can see the retina sink down into.
And same thing happens with PCV. The same thing happens with a CSCR also, because there's a focal area at that time where the RP and the choroid get affected. It just falls down, and you get a non-conforming lesion.
Yeah, so just the last comment is just, I think the thing I was missing is that you need to have a defect in Brooks membrane.
Yes.
Brooks membrane supports the retina. Without it, the retina sinks in. You can see it after trauma too. A choroidal rupture, the retina sinks down, forms an excavation.
But there are a second group of patients which are primary. There is a congenital group also where first nothing is there. As long as they are there, it's only a conforming lesion, nothing else is there.
Yeah, thank you, Dinesh. And now we go on to the next choroidal knuckle by George Manayath.
Good afternoon, everybody. My case is choroidal knuckle or choroidal vascular knuckle. As we know from ICG angiography, early nodular hypercyanescence with or without a halo of hypocyanescence associated with branching vascular network is diagnostic of PCV. Whereas the Everest study, report 3, they looked at the diagnostic challenges and lessons learned from the screening failures based on ICG angiography in CSC, in PCV. So non-PCV lesions that mimicked PCV on ICG angiography not only included RAP, retinal macroaneurysms, microaneurysms of DME, RP window defects or RP staining, but choroidal vascular knuckle.
So my case is a 72-year-old male patient who had multiple injections of intravitreal injections with a diagnosis of focal CNVM. Because he had a suboptimal response, he was referred for query PCV for management, and he has 612 vision in his left eye with an irregular PED with sub-RP hyperreflectivity and subretinal fluid associated. Going through the ICG angiography, early to the late frames, there is a subfoveal neovascular network that is seen, but in the superior edge of the network from the early till the mid and to the late phase, where the washout of the dye happens from the network, still this area of ovoid nodular hypersenescence that is persisting, giving a suspicion of PCV or polyp at the edge of the superior edge of that network. When we went back to the early frames of ICG, the first 1 minute frames, one after the other, this is a 14-second frame, we could see that nodular hypersenescence was in fact continuous with this feeding choroidal vessel part of the membrane, and what happens at the edge of the network when it dips down, it gives increased hypersenescence simulating a PED, polyp. And when there is a change in the course of the choroidal vessel, especially where it acutely changes the course, there is an increase in the blood column at that location, giving an increased intensity on ICG angiography, simulating a polyp of a branching vascular network. So it is important for us to understand that since ICG is the gold standard in diagnosing PCV, and ICG guides the management of PCV, to be aware of these lesions that mimic PCV on ICG angiography. So that's about this case.
Yeah. Now we have Dr. Manish to discuss the case.
Thank you. I think George has presented it very well. Frankly speaking, when Anirudh sent me this case, I was first struggling to find where is the pathology on the OCT. And then I think Navneet helped me understand that, no, this is an ICG-based finding, that we do a lot of ICG for PCVs, and that's where this whole terminology comes from. So the PCV ones, we are used to seeing the very early phase to diagnose most of these polyps. And I don't think over the years we've been really looking for the late phase, since the spectralis we've been using. With the other ones, we used to see the late phase. So we've hardly had a chance to look at what is called these choroidal knuckles. But as George rightly said, that these issues came up during the Everest studies when a lot of polyps, some of them got misdiagnosed because of these acute changes in the vessels which were seen in the late phase in these. And these are some of the pictures from the Everest, which is bringing out the the kind of conditions which were misdiagnosed to be polyps. And they could have been an RP window defect, which kind of looked like a polyp and showed a staining in the late phase, or could be an early hyperfluorescence persisting in the late phase due to RP atrophy, or could be just a change in the course of vessel. So all these are depicted that we may confuse them with a polyp, and these were listed in the study, and that's where this whole choroidal knuckle came up. And I think we never used to do late phases, and we got back and tried to look at some of our cases, and something like this looked like a late phase of a condition where there was a turning of a vessel which still kept showing this kind of a staining. By the end of it, it looked like a polypoidal, like a branching network, but is not a polyp in this case. So it's something like this that needs to be looked at in these situations. And from the past, I brought out this one moving angiogram early phase where you see this, what we used to call the feeder vessels in the past. Now we don't look for them anymore, but when we did not have the anti-VEGFs, we used to go and laser these, and this is angiogram from like almost 15 years back that I brought out to show that that also disappears. It comes and then disappears. Of course, it's not connected to the PCV, but these are changes which happen over the course of the angiogram, and at which phase you are seeing them helps us interpret these conditions. Thank you very much.
Thank you.
I think Adrian was here. Maybe he would be the Colin.
Yeah.
Even Jemmy, I think, probably is.
Maybe I'll ask, because it's good that Colin's coming up so he can address this question. And, you know, as we've tried to push this, Bailey and I have been working to sort of push the agenda that we want to start calling these aneurysmal as opposed to polyps and the like. But one of the things we were recognizing, actually I was really benefited from looking at cases with Colin from the Everest 2 when I was visiting Singapore, is that we see that these lesions, I mean, you can have a fusiform aneurysms, of course, you can have saccular aneurysms, and it seems like you see both variants. And I'm wondering, if you have a fusiform type aneurysm, you know, it's sort of a subtle transition between a normal caliber vessel to when it's actually dilated. And so sometimes I wonder whether some of these choroidal knuckles may actually be still aneurysmal, right? So I guess what really we need to understand is, I mean, when we think about them, we think that these findings are associated with increased exudation, increased risk of hemorrhage. So in a way, what we need is we need to have these ICGs and then actually track to see which ones actually seem to be at increased risk. So that's my comment, but I'm interested to see what Colin or Jamie think.
Okay, yes, I think Dr. Sada has hit on a very important point, and that usually it's very difficult sometimes to tell whether it's a true polyp or not. I think one of the comments which I think you showed is that you should track the early dynamic phase ICG angiograms to see the flow of the dye. And I think the way to tell, how we tell the choroidal knuckle is that we can actually see it tracking from usually one of the large choroidal vessels where it changes direction. And the reason we feel it looks brighter is because when it changes direction, there's a larger column of dye, which therefore appears brighter on this. Other things that can help is, as you mentioned, areas of chororetinal atrophy over that area, which makes it even more prominent. And if you do stereoscopic examination, it's flat, it's not raised. And now with spectral domain or swept source OCT, you can also see that there's nothing in that area.
So you always look at a late phase in all these cases so that you don't miss out, or it's not for every case? When would you do that?
Well, in my clinical practice, I would usually look at the later frames. We still take later frames. For Everest 2, we stopped at 5 minutes, so as not to have too much of a burden on the imaging. So we wouldn't know about the late frames. And Everest 1, we did have, I think, 10 and definitely 10 and I think 20 minutes as well. And so sometimes we do see this more prominently at the later frames.
Thank you.
Any questions from the audience?
Tissue. So why are you looking for the knuckle? I mean, why are you looking in the late phase? It should be there. It should be better characterized in the early phase.
Yes, you can see it in the early frames as well, but I think it's for vascular knuckle, you can also see it in the later frames.
Yeah, we've never been looking at the late phases now for many years, so that's why we never actually thought of this.
Thank you.
Our protocol is till 20 minutes, all the standard ICG angiographies. First 1 minute of video ICG, followed by 1 minute, 5 minutes, 10 minutes, 15 and 20. You see the washout, and some of these lesions, even in their study, some of the cases like focal RP staining that appears only at the 10-minute frame. If I'm right, 10 minutes it appears and persists till the last phase. There is also a differential for polyp on ICG angiography.
And these are spectralis based ICG, right?
Yeah.
Thank you. I think we'll move on to the next case presentation of pachychoroid epilopathy by Dr. Naresh.
First, I would like to thank Dr. Shobhit for the opportunity. So much of reading is going on in the fundus of OCT, OCTA, and right field angiography or right field fundus. I'm really scared that nobody will be able to put the normal fundus hereafter. And in future meetings, we'll be having somebody presenting the normal fundus of the normal OCT of the normal fundus. And second thing I'd like to tell is I'm very happy that Dr. Brady is here actually, because he's going to be the discussant for this case, because he is the one who basically told about this condition to us. So it's a very simple thing actually. So in fundus photograph, you'll have a reduced testation with regular photography, and it's basically silent disease. What happens is if you have pachychoroid vessels, which they say used to compress the choroidal vessels so that we atrophy of the capillaries, and that leads to overlying thinning of the retina. And over that, we'll be having manipulations of the arteries. So it's very, very fine detail actually. If you go into the have two things, either the CSC or Pachychoroid neurostomatics. So this is phone number and in the right eye, the patient had a whole CSR, it was 5/60. And this is the name of the phobia. The left eye, you can make up bumpy and annihilation of the RPs. A similar finding is seen in other cases, like classic activity, and then kind of find annihilation of the RP, one of the large fatty vessels compressing the pore capillaries leading to atrophy. And it is basically a silent disease. When it becomes difficult for the RP to pump, probably it becomes like a CSR or CL. So the point for discussion is this: is it dominantly inherited trait? What are the role of PDT in these cases? Or like in case of chronic CSR, shall we go for regular norms? Whether it be useful? Thank you.
Yes, please go ahead, sir.
All right, can I have my slides? So hopefully I could, in the very brief period I have, clarify, there we go. Try to clear up a little bit of confusion because our definition of pachychoroid has evolved since the first papers on the subject. So if it ever comes up with all the blinking, you can see a really nice paper. Maybe I should just plug in there because it works on that side. It was fine from that podium. So why don't we just try the other podium? Was it? Now when we talk about pachychoroid, in that paper we tried to draw a distinction between just a thick choroid, which we said maybe that could just be called a pachychoroid, or uncomplicated pachychoroid. And that really should be distinguished from a true disease entity, which we call pachychoroid disease. And basically what at least I feel and what's in the paper defines that disease state is that it's really not so much the thickness of the choroid, it's that really these patients have loss of the inner choroid that now with OCT angiography we know corresponds to reduced inner choroidal blood flow. And if you need an objective way to determine whether or not a patient has pachychoroid disease, it's quite easy. Do an ICG. If they have choroidal hyperpermeability, then they have pathology. If they don't, it may just be that they have a thick choroid. And it doesn't mean that the entire choroid is thick. It's usually just that the choroid is thickest in the area where the manifest disease is. So you can have a patient with a thin choroid, and they might have pachychoroid disease, but the pathology, as we saw in the case of British, is typically going to be the thickest part of the choroid. And then there's a type of lesion that looks sort of like drusen. In the original paper, we called it drusenoid deposits. Richard Space come up with a much catchier name, pachychoroid, but basically it's the same thing. They look distinctly different from soft drusen of typical white AMD. So this is the point I made before. Not every patient that has a thick choroid has a disease state. And the findings I just mentioned are not necessarily caused by one predisposing disease mechanism. It could be inflammation in some cases, like in the cases we saw before that had sort of this strange overlap of central serous and lesions that look like pit. So inflammation may be one mechanism. Maybe choroidal congestion is another mechanism with compression. We really don't know whether it's compression from dilated veins causing that attenuation. Rick Spade points out that how could a venous bed compress a more arterial bed? That doesn't make a whole lot of sense. It may be that there's primary loss of inner choroid, and that particularly in the macula and around the optic nerve where the posterior ciliary arteries enter the back of the eye, there's shunting of blood directly from the arterial system into the venous, and then the venous large veins is secondary. I thought I was really going to be more asked to comment on this case, and I central serous. That would not apply to this case because, as I showed before in the talk about hyperautofluorescence with subretinal hemorrhage, this patient clearly has had subretinal fluid in the past because there's hyperautofluorescence where there's loss of the ellipsoid zone, and the central fovea is quite attenuated. So this patient has had fluid down there now, plus they have splitting of the RPE and Brunk's complex, a shallow regular RPE detachment. So they might have type 1 neovascularization, but you need angiography or OCTA to distinguish that. So I would say that this is a patient that may have had central serous in the past, the fluid's not there. Maybe now they have type 1 neovascularization. I would not call this pachychoroid pigment epitheliopathy, which is a term that I use exclusively for patients that don't have any evidence of subretinal fluid either by history or with clinical imaging. Again, with this case, there's some features that would make this not really just pigment epitheliopathy. This patient has evidence of probably some changes in the past. So there's a splitting of the RPE and Brunk's membrane. I'm just looking at the details again. So this patient may have pigment epitheliopathy, but until you look at that splitting of the RPE and assure that there's no neovascularization there, it would be hard to say whether this is pachychoroid neovasculopathy or pigment epitheliopathy. So yes, as we go into the OCT though, you can see that this patient clearly in the lower image, there's a disrupted and thin ONL. So this patient has subretinal fluid, so this is probably a patient that has prior central serous. This is the spectrum of entities that sort of fall within pachychoroid disease. Again, they all have these features here. That's what links them together. And the focal choroidal excavation, I still think, I'm not so sure whether that belongs here because there's probably inflammation at the root of many of those cases. So that's about all I have to say. As far as the other questions, treatment, I can't get to those.
I would like to ask.
The healthy thickened choroid. You want to differentiate, or why call it uncomplicated pachychoroid?
So I mean, you have patients some have myopes, thin choroid, they seraph, and I find the term leptochoroid for thin choroid. You know, and there should be a term for thick choroid, that would be pachychoroid.
Yeah.
I would reserve. So those terms I just used for thick and thin choroid, but when I'm talking about a disease state, I always add disease
With the pachychoroid.
and that's what so the disease state, the pathologic state has those features, and that's, I think, should be separated from just a patient that has a thick
Healthy
choroid,
choroid.
otherwise completely normal.
Right. Thank you.
Sir, what about the cases which are of chronic CSCR going on for a couple of years, and then they develop abnormalities on ICG, and some even drift towards PCV? Would you say it's a continuum of the same disease process?
Yeah, I think well, the people in Asia who see them more of this, they know this better than I do, but also, with OCTA, now you look at a patient that has presents with aneurysms or columns in one eye, you look at the other eye, there's type 1 neovascularization non-exudated. So what do you call that? I mean, if the patient has had CSC, then you can call this a CSC, and now they have secondary neovascularization, possibly with aneurysms. But we're seeing a lot of patients that never have fluid, but later in life, they just have neovascularization. So what do you call that? If there's no drusen, I guess you just call it a variant of neovascular AMD, but it has none of the features of typical that we define AMD like really soft drusen and histopathologic findings of basal linear deposit, basal laminar deposit. These patients don't necessarily have any of the defining features of AMD, so you have to call them something. You call whatever you want, but I think pachychoroid neovascularization does sort of help. It's descriptive in terms of what seems to be driving the neovascularization. It's not the same as what we see in typical AMD. It's probably more changes in the choroid. What is actually causing those, that's yet to be determined.
Thank you, Bailey. We go on to the next presentation on reticular pseudodrusens by Vatsal Parekh. The discussant is Dr. Unni.
Good evening. I thank Dr. Vishali to give me this opportunity to present. A typical drusen is below retinal pigment epithelium, between retinal pigment epithelium and Bruch's membrane. Pseudodrusen is above the retinal pigment epithelium. This term was used since probably 30 years, but since last 5 years it's more in use because of multimodal imaging. I'll just present this case. This was a 65-year-old male. Complaint of diminished vision in both eyes in 6 months. There is systemic history of hyperlipidemia. Visual acuity is 618 in right eye and 66 and 8 in left eye. Now, these are the lacy pattern of drusen, pseudodrusen. This is rate-free photograph, and this is fundus autofluorescence, which shows hypoautofluorescence compared to normal drusen, where you get hyperautofluorescence. Now, this is the OCT image, which shows this drusenoid, subretinal drusenoid deposits above the pigment epithelium, between the pigment epithelium and ellipsoid zone. Here probably it has broken through ellipsoid zone. This patient was investigated, but there was none, and he was lost to follow. Thank you.
Call Dr. Unnikrishnan Nair for discussion.
So just coming to reticular cerebral drusen. It's always been known, and why it's called cerebral drusen is because the location is not typically interior to the basement membrane. A new terminology, subretinal drusenoid deposit, probably covers a lot of what happens. And why it's interesting is that it's not the regular apoptotic process that happens in AMD. What the pathology and research is that it's a lipid metabolism problem at the outer photoreceptor points where there is deposition inside the just above the basement membrane and underneath, and eventually you have photoreceptor damage called choroidal atrophy. Well, the whole category of patients is slightly different. It's not elderly males coming. You have a female with hypertension, indicative of a vascular abnormality, which is at the root of there's a two-lesion hypothesis that comes in for it. One says that an essential choroidal insufficiency is what produces the variations in the photoreceptor metabolism and causes it to deposit. And the deposition eventually leads on to RP changes and photoreceptor atrophy, which is proven by certain studies. But essentially, the drusen, which I will come to later, has a progressive nature. It's like AMD on steroids or AMD on the run. It's a fast-forward process for AMD happening to the pseudodrusen. And here you can see, in these pictures, you can see there are different types where the lesions initially reach the ellipsoid and reach until the ELM and eventually penetrate out of the ELM. In this particular patient, you can see a few hyperreflective dots which probably represent the anterior migrating marking cells, with precursor to what you say RV atrophy happening later. Again, you see here lesions where it just reaches the ellipsoid zone, and you have a fragmentation of the ELM also happening at that particular region. Here you can see crossing the ELM region. Then you have regression of the drusen. This is a natural process, a fast-forward type of RV atrophy happening over here. And eventually you can see vertical hyperreflective columns in the beginning of an RV atrophy disease. So your reticular pseudodrusen is, as I said, it's AMD, geographic atrophy in a fast-forward mode. The whole significance is that the association with intermediate and advanced AMD is higher when you see reticular drusen. It is of significance when you talk to the patient. Even when the disease is not regressive, there is choroidal atrophy, the thinning of the choroid, thinning of the photoreceptor that is happening in the RPD. A lot of conditions mentioned, like nascent GA, where you have a dip of the middle retinal layer that happens as a precursor to this lesion. You can see that there's a loss here. Conditions like Aurora, Aurora, eventualities that happen in the reticular drusen over time. And again, this is a 7-year follow-up of this patient, where you can see over time you have a pseudo-uniform-like lesion, which is ending in necrosis towards the end. So on a whole, you have a disease which, the significance of which for your patients is that you have a fast-forward disease, a disease that has a tendency to go to RP atrophy on one hand, on the other hand, a disease that has a chance of developing accelerated components also.
Any comments? So,
yes. Can you come to the microphone?
Sorry, a very basic question to all the stalwarts. How do you differentiate between drusenoid RPEDs versus these kind of
I think some of the pictures were drusenoid PEDs.
Yes.
I mean, I don't know. There may be better persons to say that. And I think the most important point we need to make is high incidence of RAP. Actually, 80 to 85% of patients with RAP have a reticular pseudodrusen. So I think that's, and especially if you have RAP-like lesion in one eye and pseudodrusen in the other eye, the chance of RAP coming in the other eye within the next 1 year is about 50 to 60%. So I think that's again another important take-home message. And usually they are seen in, they come in, in groups. And I think they are more commonly seen in the upper, just above and temporal to the fovea. And
to go back to what you were saying, I do agree that like the first case that you showed is drusenoid PED. It wasn't pseudodrusen. And then to answer your question, the way to, we have experts here too, but the way to differentiate, it's above the Brooks membrane, not below. And it's more triangular and not rounded shape. So that's the easiest way to sort of differentiate.
And usually
Judy,
they come in the above and...
Let's go back to the first picture. The first.
Before this.
Yeah, Jude.
The very first one.
Can somebody get pointed to Judy so that we, get it correct?
There's one more before this.
Yeah, so those are drusenoid PED. You see that Brooks membrane.
The Brooks membrane is intact.
Is intact, and there's RPE rounded on top. Whereas if you look at a little bit off to the side, actually, those are on top of the RPE.
Go back.
Go back. Go back. One more.
Oops, here it is. All right, so this is a drusenoid PED. It's over there, okay? You don't want to stand in front of my laser. But maybe over here, it's more triangular, pinpointed, and it's on top of the RPE. And it's under the retina, but it's top of the RPE. That's the way to take difference, whereas here's a PED right there with the RPE. So here, that's a pseudodrusen on top of the RPE with sort of pointed triangular. So that's how
But in this one, the outer retinal layers are not affected. This particular...
Right, this one, it's a stage 2, yeah.
Okay. Any more questions? Thank you, Oni. We go on to the next presentation of color-specific ERG techniques by Deepak Bhatt.
Okay, good afternoon. Thanks, Vishali and our team for inviting me here. This is a little off the track from all what we have heard, everything in the morning, but it still concerns the retina and still an important factor. It may not have any clinical relevance as such in routine practice, but I have been appointed as consultant to the Indian Railways, and all this has become important after that. So if you have diagnose a color vision deficiency, what do? We take the Ishihara, and that's the end of the story. But Ishihara is a screening tool. So this is a very important point really in occupational disorders. Otherwise, color vision does not have any importance, especially for pilots and train drivers. Persons with color vision deficiency actually know that they have this deficiency, and they know how to fool everybody around. 7% of the male population is color deficient, and therefore it's a very high number. Now, these are just the images This is on the right side is somebody with normal color, and the left is somebody with two colors, and another on the left is with one color. Now you realize there is hardly any difference between people who have two color deficiency or one color deficiency. But still, if he has to see everything okay, he requires all three colors. The argument that is put forward is that if I can see a signal where red color is always on top and green is always on below, why should I have a normal color if I have to take up a job? Look at these three pictures. This is what a normal color sees. This is what with dichromats in two colors, and this is with a monocolor. Now, what happens in a mesopic state? Whenever the lighting condition goes down, and if a person tries to see this signal, he's not going to see anything on top, and this will appear to him as red because that's the brightest. So that logic does not work, that I can know the signals very well, because that's what they argue when people take jobs in these places and those who have color deficiency. So color deficiency is not somebody who is color absent, but somebody who is color deficient also. And they are the people who fool on Ishihara. So we have two situations here, one who are concealers, those who have and want to don't reveal, and there's a second group which is a malingerer, and that's where I come into the picture. Concealers are the people who easily know how to manipulate because they get the Ishihara chart from the office of the eye department, and they know that if it's 6, you say 9, and they can get through everything. Therefore, a comprehensive test is required, and we do all these 4 tests: anomaliscope, HRR, lantern, and D15, and all have to be consistent for us to make a diagnosis. Now, the anomaliscope we all know is the gold standard, is expensive, but it still gives us all the answer, and this is the report that we give. When the anomaliscope gives us a quotient which is like a blood sugar level for that patient. And this gives us a final report which cannot be challenged in court also. Now we come to malingerers. Why is there being this problem of malingerers? Now in Indian Railways, we faced a very particular situation. I think it's for 6 minutes. Where those who have taken jobs as trained drivers, if they are in the job for 3 years, they cannot be removed from job. So afterwards, what happens is they are normal people. They do not want to do the job because they are put in goods train, which goes out, has been put on the somewhere outside into the jungle for 10 hours. There are signal mans who have to go man unmanned signals in remote areas, and they don't want to do the job, so they come and say that I don't see red color. And they mock up the Ishihara and tell you that, well, I cannot see red color. So what do you do? How do you face? So this was a huge problem with the Indian Railways. And therefore, they approached me to whether we can do something objective. And therefore, I approached one Professor Jane Kramer in Germany, who is a physicist himself. And he has worked a lot on visual sciences. So I went to Germany, and he told me a big 3 hours lecture on what color vision is all about. And this is all the sum up of all that lecture. Frankly, I did not understand anything of it. But he was confident that we can do something on it. So this is after 3 hours, I said, okay, tell me in a nutshell, what do you want to tell me? He said, we can differentiate between protonopes and deuteranopes. And this is, in short, what it means. When we do a normal ERG, we stimulate the cones, both the L and M cones, which are for green and red, with 30 Hertz frequency. With 30 Hertz frequency, it gives the luminescence property. That means that it tells us what is the brightness, and therefore we can differentiate between rod and cone dystrophy. But when we use the 12 Hertz frequency, it shows off a chromatic signal. And this chromatic signal helps us to differentiate whether there is a red or a green deficiency. And this establishes a diagnosis. So we formed a program, and we worked on this, and they published the first paper here that we can do an objective color vision testing. And this was a paper with 98 patients, but now we have around 250 patients. What it means is this is a normal graph. Between 4 and 6, if you fall here, you have equal red and green, means you are normal people. And then when you are in the red zone, you go beyond 6. And this is how you diagnose a red deficiency. I'm not going into the details, it is too much of physics involved in that. And this is in the green zone, when you are below 4. So this requires a specific Gans field, which can throw off specific lights. And there are protocols, it takes a good 20-25 minutes, but we can diagnose what is the state of the patient without doing anything. It's a total objective color vision testing, which can probably solve a lot of problems for us, for the employers, and for the patients.
Can you summarize, please? Can you summarize?
What?
Is it done?
Yeah, it's the last slide. So we have an objective color vision testing for transport industry, and it is fair to the patient, and it is also for our safety. Thank you.
Parveen.
Without taking too much of time, I think I'll do a very tough job of trying to simplify what Dr. Deepak has just now mentioned. And this is just a summary of what he said. There are 3 types of cones, and depending upon which is present and which is absent, you could have various forms of color blindness or color deficiency. It's an important concept that Dr. Deepak has brought, that ERG can be useful to differentiate and bring out the color deficiency and to find the ratio between the number of red cones, the blue cones, and the green cones. The goal of the present work was to objectively assess whether they could find out who is colorblind and what kind of color blindness he has. And this can be done, it's possible, is what the paper has shown. And this is dependent upon the ratio of the L cones or the long wavelength cones and the M cones or the medium wavelength cones. Problems that they encountered was, we have done these tests on non-dilated pupils. So the full extent was not available, no age match controls, and there was a lot of overlap between protolobes, deuterolobes, and trichomats. So distinction still is not possible.
No
but it is an important step.
A question.
Another thing, to complete the topic of chromatic ERG, I would say that chromatic ERG can be used in various other clinical scenarios as well. Even chromatic BP can be used, and this is another classic example where chromatic ERG is of extreme importance. Something which we diagnose as enhanced S-cone disease, where the number of blue cones or the S-cone is hugely increased and there are no L and M cones. So this kind of a retina gives you a natural substance where you can see what the S-cones behave like, and this is the various pictures which could be present, and this is the ERG, how it looks. This is only S-cones firing. So the moment you see this kind of ERG, you know there are no L and N cones, only S cones, which is a broad wavelength, and you can differentiate between the two. If you give an orange flash against a green background, that is a chromatic ERG, it is flat. But if you give a blue flash against an orange background, you give large amplitude waveforms. So this ERG differs according to the color of ERG that you have used and according to the kind of cells which are present. Another important region where it is of extreme use is, again, chromatic ERG, diabetic retinopathy. We all know diabetic retinopathy affects the blue cones or the S cones much earlier. So, in this kind of a thing, if you give a blue stimulus, the blue ERG is affected. And if you see the ROC curve, this work has been done in Chairpersons. Blue ERG is so much more sensitive to pick up defects before even manifest ocular retinal disease is present. Opposite happens in glaucoma, where the red ERG or the red chromatic stimulus causes more defect as compared to the blue. So this is the role of chromatic ERG. It can go beyond the limits of a normal white ERG.
Thank you, Parveen. Can I have Dr. David Sruff commenting on it? You've done so much work on David. And while he's on, I have a question. So all the drivers in Indian Railways go through this test?
No, it's only those who are suspects they go through, and those who are malingerers.
Because sometimes we have these accidents occurring with the drivers having jumped the signal. So
Yeah. So minority of times it is the color problem. I'll tell you an example. I had last week a pilot coming inside who was a suspect color vision. He came inside, and before I did the test, he asked me, "Are you really going to find out what it is?" I said, "Yes, we'll be able to make out what it is." So then I don't want to do the test. I'll somehow the other manage with the management. He's been piloting for 10 years. I said, "You can go, there's no problem. I'm not going to do the test. At least tell me which airlines you are flying. So next time I will not buy the tickets on that airlines." So that's the seriousness. And actually, mind you, I'll just take a half a minute. I have gone on the railways and with the pilots to see exactly what happens. Whenever the lighting conditions go down, you know, though in normal lighting condition, they see very well. If they go down, it's a massive difficulty for them to see the signals, especially same in the aviation industry. So it just an topic which cannot be taken lightly. And they fly hundreds of people and travel every day. And we also do that. So it's important for us.
That is very impressive. Dr. David?
Yeah, sorry.
Just make a comment about enhanced S-cone syndrome. One of the ways we use ERG to make the diagnosis is to look at of course you have a superpopulation of S-cones as you beautifully illustrated in your nice talk. And so what happens is the photopic ERG, the scotopic ERG takes on a photopic morphology. And so we talk about maybe the photopization of the ERG. So that's another way in which you can look for a indication that you have an enhanced S-cone syndrome. And then, of course, you do the NR2E3 genetic testing to confirm the diagnosis.
The photopic ERG looks identical to the scotopic.
That's right. That's right. Because you just have a superpopulation of blue cones. You have essentially no rods, and so they're driving the scotopic response.
Yes, Jose.
I have two questions. One, why choose 12 hertz? And number two, from the work from Jeremy Nathans, there's a real gradient as opposed to blue, which we were just talking about. But between red and green, there's a big, the action potentials, the action spectrum for red and green is very mixed, especially in males because it's the same gene basically. So how reliable is this test?
There's a lot of modification which has occurred from the time we started doing it about 3.5 years back. And Jane would be the right person to do because a lot of physics involved in that. We'll be publishing our next series of more than 400 patients and where there's a huge modification done, which could serve answer. Yeah.
I think
the question, it does cause an overlap. In their study also, they could not differentiate categorically between quaternions, deuterons, and trichrominous patients. They were not able to differentiate because of the overlap. The spectrum of L, M, and S cone is overlapping, so distinct boundaries are not there. That is one of the limitations of it.
Thank you. I think we'll move on to the next case presentation, MMI in capillary versus cavernous hemangioma by Dr. Paritosh Kamdar. And Prithvi, last Prithvi to be ready as discussant.
Thank you, VRSI, and thank you, Vrishali, for having me here. This was a 29-year-old lady referred for macular edema, vision 6/151, less than N48. What was missed by the previous ophthalmologist was this capillary hemangioma sitting out there. And these were the OCT pictures. At the macula, as you can see, there's not only subretinal fluid with some amount of shed segments, shed material from the photoreceptors, but there's also something like a skytic cavity over there. And this, of course, is through the capillary hemangioma. This patient, the first patient, was lost to follow-up with me, so I don't have further data, but was treated with cryo by another colleague. Case 2 was a dental surgeon. Presented with good vision, but just floaters. He had been diagnosed to have GI tuberculosis, and so I found this sheathing here, some bleed here. On a very busy OPD day, I said that I'm dealing with and some pigment clumps there. So I said it must be eels and went ahead and did, I didn't think too much of this OCT, and I just did workup for eels. I went ahead and treated with laser, but there wasn't too much of regression, and so then sat down and actually saw these bulbous outpouchings over the surface of the retina with some amount of vitreous attached to it. And so that was the eureka moment. Then the next question was, do I treat it direct with laser or not? Now, points in favor of treatment were he's had a bleed already, although it's not affected vision. So I went ahead and did focal treatment, and so that was before focal treatment direct to the cavernous hemangioma, and this is immediately post. 4 days later, he had a rebleed, and this was the picture. There was partial regression, but and then he presented 3 months later. So that was before focal treatment, immediately post, and this is about 3 months post. So the fresh bleed which had occurred over it has partially cleared, and this basically is the two conditions differentiated.
Prithvi.
So this is a tale of two hemangiomas. So thanks to Dr. Bartosz for the excellent cases. So when we talk about cavernous versus capillary hemangiomas are sporadic. They are rare, maybe about 100 cases in the literature, and typically unilateral. Capillary hemangiomas, we know, are related to genetic disease. They're more common than cavernous, and typically bilateral and often multifocal within the same eye. The pathology helps to guide what we see with the clinical imaging, with cavernous hemangiomas having large spaces that have sedimented erythrocytes without smaller vascular channels, compared to the capillary hemangiomas that have these smaller channels that are lined and have minimal erythrocyte sedimentation. And of course, we know the systemic manifestations with odd-nipple Lindau disease with capillary hemangiomas. So this is one disease where fluorescein angiography really matters. So in a capillary hemangioma, especially with the exophytic lesions, you can see this lesion in the supratemporal periphery. We notice first the efferent and afferent vasculature that's well highlighted with angiography. We see the early fill and late leak, and often we can see clinically undetectable lesions with angiography, especially with wide field systems, and there can be exudation and subretinal fluid. With the endophytic type of capillary hemangioma, these can often be diagnostically challenging because they can look like, for example, an amelodytic melanoma. This is a lesion near the optic nerve. We can see the vascular activity on the angiography. There's leakage within the macula and the high reflectivity on ultrasound. The OCT is most helpful because it shows that this is an interretinal proliferation, not something from the choroid coming up, but actually within the retina itself. The cavernous hemangioma is the classic cluster of grapes. Whenever we see this, it's exciting because it's such a rare finding and so beautiful to see. There's normal retinal vasculature, however, with the cavernous hemangioma. There's a cap of fluorescein in which there's hyperfluorescence seen on the apical portion of the hemangioma and hypofluorescence seen where the erythrocytes have settled. The OCT can often show these saccular dilatations. There's one report from Ed Simpson's group in Canada that showed these fluorescein caps, but also extensive areas of peripheral non-perfusion. So not a common finding, but might be reasons why there's hemorrhage in some of these cases. Again, to differentiate these conditions, cavernous hemangiomas usually are stable, have good vision, and can have mild complications, whereas capillary hemangiomas are progressive with guarded vision and often have pretty bad complications. And we typically observe the cavernous and treat the capillary. This is where OCT angiography I'll touch on briefly. So OCTA and cavernous hemangiomas can help to identify the lesion, especially in a multimodal standpoint. Here we see a lesion by the edge of the optic nerve, and OCTA shows the flow within the lesions themselves and the extent of the lesion. And if we look at other conditions within cavernous hemangiomas, within the temporal portions of the macula, we can see that there's actually development of vascular anastomoses with the venous system. And in this condition here, reported by Chawla and colleagues, there's actually an inverted cap that's seen on fluorescein angiography, but is seen with OCT angiography. And finally, we can see with capillary hemangiomas the classic appearance of the
I think the second patient that you showed had a vasoproliferative tumor. You know, I'll give it to Jose.
So I don't know if it was, that's definitely in the...
It's definitely in the, it's very much so in the differential.
Yeah. But there was no liquid exudation that he had there.
You don't, so the patient had a history of having Eels disease before and had some sclerotic vessels, and it sure looked like a secondary vasoproliferative tumor. The other thing is, I think it's very important to make sure, and the pathology and the animal model confirms it. When one talks about the von Hippel-Lindau diseases, those are hemangioblastomas. And the paper that just came out by Chi-Chao Chang of the mouse model shows that they are hemangioblasts. So let's use the proper terminology in these things.
Yeah, Dhananjay.
Yeah, I would also just make a note that with the retinal cavernous hemangiomas, not always sporadic. They can be associated with CRIT1 mutation, and these patients can also have cavernomas of the brain and even an autosomal dominant association. So that's something that I think needs to be searched for with the patient.
Yeah. Also cutaneous manifestations.
Yeah. That's exactly right.
Yeah, the second patient did have a spinal cord lesion.
In those situations, those are the patients that have a greater likelihood of a neural event.
Yeah, cerebral.
Yeah, he had that's right. Yes.
Yeah, Dhananjay.
One small thing I wanted to add is I didn't hear the term retinal. So actually it's a retinal capillary hemangioma because the second case you showed was looking more like a choroidal capillary hemangioma. So it's a retinal capillary hemangioma what you are talking about, not the choroidal hemangioma. Because the second case was looking like a choroidal hemangioma, the one on the desk.
No, it wasn't actually. So
it is a differential diagnosis since melanoma, amyloidotic melanoma is a differential. Capillary, the choroidal hemangioma is also a differential in that case.
So it is in the differential. So you have different types of retinal capillary hemangioblastomas. I like to be corrected by Dr. Pujo, where you can have endophytic exudation. So the ones by the optic nerve are often the endophytic and sometimes the sessile, which can mimic the appearance of a melanoma. You have to consider a choroidal hemangioma in the differential, but OCT is going to be very helpful that way because with OCT you'll see the elevation and the dilatation within the choroid itself. You can do an ICG as well, but this was clearly within the retina, and again, it would be very easy to think of it one way or the other, but it's important to use the differentiation.
No, and the other thing too is they're totally different diseases, right? So the capillary hemangioblastomas are associated with the VHL gene that is that has the VHL protein that causes ubiquination of HIF, and in the absence of it, you get elevated HIF levels once you get a mutation. In a choroidal hemangioma, what you have is a somatic mutation in GNAC in the endothelial cells. So totally different diseases, totally different genetic backgrounds.
So, just one comment about why it was not a vasoproliferative tumor, my case, because there wasn't exudation. I mean, vasoproliferative tumors generally get detected because of a lot of exudation.
Correct.
So that was not there in this case.
But sometimes you can catch them, without it too. So it depends upon the size, the amount of leakage, and sometimes they're just there.
Thanks, Prithvi. Thanks, Paritosh. We go on to the next one, hyperreflective retinal dots on the OCT by Sashank. And the discussant will be Dr. Gaurav Shah.
Good afternoon, everyone. So I will be presenting a very simple findings of hyperreflective dots or foci. So it was detected in 2009 by Kostas et al. And previously unseen intraretinal changes on SD-OCT, which has been termed as hyperreflective dots or foci. By definition, these are small, scattered, non-confluent, punctiform lesions with no backshadowing seen in various layers of retina on SD-OCT. These are not visible on color fundus photography, angiography, autofluorescence, monochromatic, or blue light fundus photography. initially seen in neovascular AMD, but later found in diabetic retinopathy, DME, retinal vascular occlusions, CSCR, IMT, uveitis, etc. The slides are not moving.
There are different hypotheses about the origin and nature of these spots, but most popular one is that of inflammatory markers. Coming on to the cases, this is case 1 of a 47-year female, poorly controlled diabetic for 16 years. Respiratory vitellicity, both diagnostic 6-part and 6. Intersegmental was unremarkable and fundus was remarkable for severe anemia with central involving DME. Coming on to the reverse pictures of OCT in the right eye, you can see there are multiple spots, majorly in the inner retinal layer, but also in many other layers. Above scan and the inferior scan, you can see these small dots, these are known as hyperreflective spots. But these larger, confluent, deeper spots, these are hard exudates. How to differentiate between these two is there is a back shadowing and they are more coarse, confluent and on the deeper layers. Going to the other eye, the same findings you can see that these small black dots they can make out in different layers, majorly around this interretinal fluid and inner retinal layers in diabetic retinopathy, and again the hard exudates in the lower picture with the back shadowing layer. So these are 3 color fundus photography, grayscale and the reverse grayscale. In my opinion, these are best appreciated in reverse grayscale, but can be appreciated in the grayscale, but less commonly in the color photography. So going on to the right eye follow-up pictures, when the patient was controlled with the diabetic retinopathy was controlled 3 months later, you can see that edema goes down. The number of these hyperreflective spots have gone down in both the pictures. But again, patient developed diabetic nephropathy sometime later, and when the edema comes back again, the number of hyperreflective spots has gone up again. And similar thing happened in the left eye, as you can see from going from the first image to the third image. Second case is of a CNPM in the left eye of a patient of 74-year female with blood vision 4 to 6 weeks, diagnosed as CNPM. Now again in this picture you can see the CNPM. In CNPM these reflective dots are seen majorly in the outer retinal layers and in and around this SRM and the intraretinal edema. These are the 2 scans from the same patient. And when we give treatment of anti-VEGF, they progressively decreases from first line after one anti-VEGF and the second anti-VEGF. If you just get rid of this, you can see lesser number of spots on the base, from the baseline to the first and the second one. So whether these are very simple findings to see and observe, but whether they are clinical significant or not, we'll hear from Dr.
Thank you. I actually don't have any slides. I just found out about 2 hours ago about this. So we'll just go right from top. I think that you made really a couple of very good points. One is, in order to figure out these spots, you must see them first, right? So on your OCT, since I don't have slides of my own, we'll borrow your slides. If you can put his slides up, please. You need to look at these on white on black rather than black on white, because what you'll find is the ellipsoid zone in these spots are much easier to see when you look at it that way. Number 2 is, how does this help you clinically, right? So the way I look at these spots is these spots really represent retinal barrier dysfunction, whatever that might be. So you can look at these spots and you can sort of figure out, and I talked about this at the pre-academy meeting, even for vitrectomy surgery, that the Japanese have shown that when you have these foci, hyperreflective, these spots in the outer retina, prognosis for vitrectomy surgery for them in terms of vision is much worse, okay? So the question is, does the external limiting membrane dysfunction lead to this or vice versa? Nobody really knows that part, okay? But I kind of use this to judge my patients in terms of how often do we see them, how often do we follow them, and if I see more of the black spots in the outer retina, that changes how I follow and maybe how I treat them for the future. So that's how I look at spots and dots. Now, David may come up with something next year that could be a spots and dots combination, because there's a new term, knuckles and spots and dots, but I do think that these are important to keep in mind. These are not artifacts as what some people thought they were. So those are my slides.
I would like to focus on one point which Dr. Vishali had raised in one of the meetings, that the presence of HRDs in diabetic macular edema are one of the indications for initiation of therapy with steroids rather with anti-VEGF, and I would like her to comment on the same.
And while Vishali is commenting, I'd like to ask the panel that these HRD occurs in multiple pathologies.
Exactly. Yeah.
So what is the basis behind, HRD occurring in multiple pathologies, and, they all respond to common treatment?
You carry on.
Well, I'm very interested in these hyperreflective foci, and we recently published a clinical pathologic correlation that I think at least explains some of them. I think you first have to ask yourself, what would produce such a high level of reflectivity? What type of cell would do that? And I think the obvious answer is phagocytic cell, because they have multiple lysosomal storage granules, and there's multiple reflective interfaces between all these little granules that could produce that degree of reflectivity. So what are the two types of cells that could look like that? Well, one would be phagocytes, whether they're coming from resident microglia or for their systemic circulation, would one. And it'd probably look almost identical to RPE cells that migrate up into the retina and have a similar thing where they have multiple melanin granules or melanolipofuscin granules. So I think by far, almost all of these are those two things. And in AMD, it's probably one of the few where you get RPE cells migrating up. Degenerative disease, inherited, yes, that as well. But most of the time, it's probably just phagocytes. And it's an interesting thing to just watch what happens in DME. You see these hyperreflective cysts that form. They show an interesting flow artifact called SPIM, suspended scattering particles in motion on OCTA, which is almost certainly lipoproteins that are showing Brownian motion. So when you see those hyperreflective cysts, all of a sudden these little hyperreflective foci appear. Those are probably phagocytic cells just gobbling up all that lipoprotein, and then they clump together and form a hard exudate. So I think all the lipid that you can see in the retina clinically on a photograph, that's really just a cluster of phagocytes or foamy macrophages that have that. And that's really all we're seeing with these hyperreflective foci.
So that answers. So you have phagosomes and you have macrophages. So probably there is a component of inflammation acting in those. So that's the concept.
Yeah, and I think, Michelle, these are really surrogate markers for potentially bad things occurring or going to be occurring. That's how you got to look at it. Like something bad is going to occur or is going to occur when you see black stuff in the outer retina.
So you got to be very careful and monitor them. Yeah.
But if they were lipid laden and you're treating them with steroids and they disappear, why do they do that?
Because I mean, I haven't proven this, but I think this is the way that the retina has adapted to clear this material from the retina. So it's collecting mainly in Henle's fiber layer in those cysts, and then these cells come in and they gobble it up, and it takes probably a long time after the leakage stops for that to eventually, those cells to find their way out of the retina, or maybe they go to vessels and they just secrete it back into the systemic circulation. I think that's a very slow process, but the leakage has to stop before that can happen.
Okay, thank you.
Can I ask a question related to Dr. Shobhit's? So in case we see hyperreflective dots in outer retinal layers, should we be giving trial of anti-VEGF for diabetic macular edema patients, or should we directly be going to
As
steroids?
a first line, we should be.
And how long should we wait?
No, we don't have guidelines on this. It's just that if you see them, be careful.
So we go on to the next presentation on lamellar hole associated epiretinal proliferation by Dr. Vishal Agrawal, and discussant is Dr. Dilraj. Dilraj, can you come in front? Yeah, thanks.
Good evening. I'll be talking about lamellar hole associated epiretinal proliferation, LHEP. So our patient is a 80-year-old male, and he complains of mild metamorphopsia and slight diminution of vision in the left eye. Both eyes are pseudophakic, And he's in follow-up with us since 2011. The last follow-up was in 2017, and the right eye OCT was more or less normal. So left eye, he presented in 2011. As you can see, there is a lamellar hole. There is a epiretinal membrane. And when he came back in 2012 for follow-up, we can see that there is a epiretinal proliferation on the nasal edge of the lamellar hole. And you can see that the horizontal diameter of the lamellar hole also has increased, although the vision was still stable and the metamorphopsia was stable. Move on to 2016, I'll just make one more note that there have been some cystic changes now developing in 2012 in the nasal aspect, which coalesced to form a large, middle retinal layer cyst in 2016, again on the nasal aspect, and now the epiretinal proliferation has increased. And in the last visit in 2017, we can find cystic changes on the temporal aspect of the lamellar hole and epiretinal proliferation on the temporal edge also. Interestingly, all these follow-ups have intact ellipsoid zone. So it has the LHEP progressively increased over both nasal and temporal edges of the lamellar hole, and both edges of the hole have developed cyst over the years. Ellipsoid layer remains intact, and of course no surgical intervention was performed in view of the age, good visual acuity, and minimal symptoms. So its LHEP in general is identified on LCT as a thick homogeneous material of medium reflectivity on the edges of the hole, and it's typically contiguous with the middle retinal layers. And it's thought to be a proliferation of retinal glial cells, more specifically Murrell cells, onto the epiretinal surface. And the reports in literature are conflicting. Some say that they progress in nature, have large tissue defects, there is a disruption of the ellipsoid zone, they don't do well after surgery, and some reports say they do well after surgery. So our case shows progressive increase in LHEP and the middle retinal cyst formations, but with an intact ellipsoid zone and good visual acuity. Thank you.
But what are some of the characteristics that we find in the GP or left? It's located on the epiretinal surface, and it's typically a substantial material of homogeneous medium reflectivity, as Dr. Farnsworth showed us. It's also important to differentiate between a tractional luminal hole with an epiretinal membrane that's typically seen as a thin hyperreflective line, which is what the case had originally, compared to a more regenerative type of luminal hole with an LHEP that does not have substantial contractile properties and doesn't have the contortion of the underlying tissue. So why does that matter? Again, Dr. Farnsworth showed us that eyes that had a luminal macro hole with that were associated with poorer visual acuity as well as a higher incidence of disruption of the ellipsoid zone. There was another study that looked at surgery in these eyes, and they showed that eyes with luminal macro holes and left have poor visual outcomes than those with just a standard hyperreflective retinal membrane. So we decided to look at some of the long-term outcomes of this in a standardized fashion and collected cases from several centers, and these were eyes that had at least a year of follow-up and registered OCT scans with that. And just like you had pointed out, the increase in the left area, we actually quantified the left area on the central foveal scan and also measured the middle diameter of the luminal macro hole as well as the inner diameter and what was the residual central retinal thickness. So over a period of 3 years, we found that the vision declined by about 0.1 logMAR, and there was an increase in the area of left on the epiretinal surface as well as an increase in the ellipsoid zone loss that correlated with the vision decline. This is an example that shows you over a period of 5 years, starting from baseline 2040, 2 years later, vision declines to about 2060, and then 5 years later, the vision's gone down to 2100. And you'll see on the column on the right, highlighted in yellow is the area outlined for left. This is on a central foveal scan, and you'll see that there is a substantial increase in the area of left, as well as a reduction in the central retinal thickness and an increase in the inner and middle diameters of the metamacular hole. As Vishal pointed out, this is thought to be a mular cell origin. And Obama et al. For Japan showed this from vitrectomy specimens that there was yellow pigment typical of carotenoids that originate from the macular xanthophyll pigment. We also know that the metamacular holes with depth do have a poorer visual prognosis in the long run, and they also have potentially a higher rate of visual acuity change. This is a comparison of our study with some of the others. And in the end, we also showed that there was an increase in the area of ellipsoid zone loss as well, and similar findings have been shown in Dr. Khan's group. Thank you.
Raj, I have a question, and for the OCD experts, then if you have a case where you have an ERM with LEP at the same time, we know that LEP basically is not contractile because they are fibroblasts but not myofibroblasts, while ERMs are fibroblasts. Do we really need to peel them?
So it depends on, first of all, the visual acuity and patient symptoms, and secondly, you should look at the other anatomical characteristics as well, such as outer retinal integrity, and if there's any progression. If you have poor vision at baseline and a large diameter of the middle hole, potentially outer retinal changes, I don't think you'll get much visual benefit.
No, so should you only peel the ERM and leave the LEP behind?
Yes.
Because they don't have any contractile properties, so you're surgically peeling them is of no significance.
If there's good vision to begin with, and the outer retina is intact, I would peel the LHEP too.
Okay.
Spare the fovea, not peel it off, just trim it down.
Okay.
Excuse me, I have one question regarding the surgical part. Now, retrospectively, if we see, we have operated quite a few LHEPs. Now, the problem with that is that it's quite tenacious, it's yellowish, and it does not get peeled off from the fovea. It's a thick yellowish glial tissue. So, how do you proceed? Where do you peel, and how much do you leave alone? Because it's stuck to the macula, the foveal center.
So, like I mentioned, I would peel it.
So, the ERM comes out easily, but the...
Then just trim it down over the fovea, and typically end up putting a gas tamper on these patients because there is a risk of progression in the thickness hole.
I think the best is to have an ILM peel, which you do, and with that you assume that.
No, but it comes with the ILM peel. Normally, if you're peeling the ILM, it comes with that.
It comes off with ILM.
Yes, Dr. Schmidt.
Yeah, I'd just like to make two comments, because when you see such a thick deposition on top of the retina, very often it's a vitreoskisis that has occurred. So what you're dealing with is, in fact, not only a membrane, but contracted vitreous. So that may be difficult to peel, but I would avoid the fovea. And with regards to the traction, if there is a tractional element, you should see some rearrangement of the vasculature, which is pulled more towards one another. And that may be a sign, in fact, that it is tractional and where a peel might, in fact, be effective, since it will allow the retina to take a more normal position. But if you don't see that, I don't think you're going to help the case very much.
Thank you. We move on to the next talk, case Pachychoroid by Dr. Rajesh, and discussant will be Dr. Chen.
Thank you, sir. It's been a few months back when I was first introduced to this term. Frankly, I didn't have any knowledge about it at all. So I went back to study what was it basically. So I knew about the typical soft drusens, which are deposited between the RP and the Brooks membrane, which was discussed previously, and the subretinal drusenoid deposits, which is above the RP. So where did this Pachychoroid come? I mean, whether we had ever seen these cases or not. But when we retrospectively looked into, after studying the Spade articles, we could find these kind of large deposits which were isolated in and around the macula. So Pachychoroid is basically a coined term by Spade. It's a distinct form of drusen. What he describes is more than 125 microns as compared to the other soft drusens. Its grouping is in and around the macula, not at the peripapillary area, and the pattern of distribution is typically different as compared to a typical soft drusen. It's always associated, that's what has been marked, it's always associated with a thickened choroid. So my representative images could see. So these are distributed drusens which are not typically round like the soft drusen, neither it's deposited in and around the peripapillary area. So the autofluorescence representative images of the autofluorescence of the same. So how do I differentiate?
So pachychoroid is basically scattered, distributed over the posterior pole, aggregate around the optic nerve, and occur in isolation or in groups. As far as soft drusen are concerned, it's aggregate in the central macula and shows a declining size in the radial extension. Characteristic, as I've already described, the location of the different types of drusenoid deposits. Coming to the importance of this, the mean subfoveal thickness when they calculated for the different groups. As far as the soft drusen group, it's not much of a change as compared to the normal ones. It's about 227 micrometers. As compared to the subretinal drusenoid deposits, which is approximately 167, and pachychoroid, which is about 419. So what it comes out is two distinct things. If a patient has a pachychoroid, then he has a pachychoroid. And if the patient has subdrusenal deposits, it is a harbinger saying that there will be some kind of an atrophy which the patient will encounter in coming times. And SSD is the only thing which is associated with a decreased microperimetry and a dark adaptation. What I learned, so I went back and looked into all the retrospective cases which we had seen for the past 2 years, and then continued it prospectively to see whether it really validates in our patients. I have around 47 eyes with pachychoroid, and all of these patients surprisingly turned out to have pachychoroid or pachyvessels. Thanks.
Thank you very much for the very nice case and the examples. First of all, I think just to clarify the point about pachychoroid again, so far, considering the association with pachychoroid, we've been really using choroidal thickness, but I think there are many other morphological factors that we also need to take into account for pachychoroid. So you've already shown very nice examples of the various types of drusen. I just want to add a few features. So this is a case of actually soft drusen right in the middle, but if you look more superiorly, you can actually, if it projects very well, that you can actually see some pseudo-drusen there. So there are cases that have two types of drusen, so it may depend on the location. But as you've pointed out, the SDOCT is very useful, and Judy's pointed out clearly that this type are deposits under the RP or between the RP and Brooks membrane. So this is a soft drusen, and this is a case of pachychoroid, very similar to what you've nicely shown us. And first question we wanted to ask is, are pachychoroid at the same plane as normal soft drusen, or are they like pseudo-drusen? And in fact, we've seen multiple times now that pachychoroid are actually at the same plane as normal drusen, so they are under the RPE. So that makes us think then if they are deposits, essentially deposits outside the cell at the same plane, then why should we make a distinction between soft drusen and pachychoroid? We so far don't have a histological analysis of what are the components of the pachychoroid, which what we're needing here, but you again have shown this paper showing very clearly, and Dr. Spade has clarified a few points that helps us distinguish these types of drusen. So first is the morphology. So soft drusen tend to be round, and they are in clumps, they're grouped together, and in terms of the location, they tend to be in the center of the macula. They may be associated with focal hyperpigmentation, as in this cartoon here, whereas pachychoroid, they are different in several ways. First, the individual drusen's morphology, they don't tend to be round, they look a little bit more discrete. And when we come to epidemiological studies using the Wisconsin classification, they tend to fall into the soft drusen with distinct borders type of lesion histologically. Now, on top of that is in terms of the grouping, they tend to be isolated or in just groups of a couple of them, not in big groups like the soft drusen. And finally is the location. They tend to be outside the central macula. So having said that, these things are helpful, but I think we've done the study and we found that still this is relatively subjective. Okay, we accept that. So then moving forward, maybe it will help to use some sort of semi-automated imaging processing to help us, for example, put a number to the circularity. So you can do this kind of subtraction, and you find that soft drusen has a more circular outline than pachychoroid. So some more examples here, and you can see that pachychoroid are also associated with thick choroid, and this is actually a pair of eyes from the same patient with PCV in one eye and CSC in the other eye, and again showing you the SDOCT. I think two areas of the significance is that it helps us understand that pachychoroid maybe help us understand that they do fall within the AMD spectrum. So I'll skip a few, and I just want to show that this is one case that we show after 6 years. That is the typical eyes with soft drusen, and they progress to late AMD. Accepted, this is what we expected. And this is in the Asians. We said traditionally they were classified in our epidemiological study as having no drusen at baseline, and somehow they got neovascular AMD. So we don't know what's going on with this kind of patients. We say maybe they don't have AMD. Now looking back, actually this eye has pachychoroid here. So maybe this is another way that so-called AMD expresses itself in an Asian population. Maybe that's because there's a difference in the background of the choroidal morphology, and that changes the way that neovascular AMD or non-neovascular AMD expresses itself. So this is one last slide from Dr. Spade, who suggests that patients who are doomed to have AMD of some sort because they have the AMD-associated SNPs, we're going to get drusen of some sort and later neovascular AMD of some sort. But in between, if the local environment, such as choroidal morphology, is different, then it changes how it shows itself. So those with thin choroid would then tend to show pseudodrusen and RAP, whereas those with thick choroid show pachychoroid and maybe PCV. So I think there's still a lot of work. This is just in its infancy, but a very interesting area. Thank you.
Thank you. Any questions? Or we go on to the next presentation. Peripheral exudative hemorrhagic chorioretinopathy by Ramandeep, and a discussant will be Colin 10. Colin, can you? Yeah.
Good afternoon, everyone. I quickly move on to my cases there. So this is an 88-year-old gentleman. He presented to us in 2015 with left eye loss of vision. He had this CNV in the left eye, and the right eye, which was a seeing eye, he never knew that he had a CNV there. So he was very irregular in the follow-ups and the getting bevacizumab injections. So after 2 years, what happened is he developed this lesion in the right eye. Now in the right eye, he has this lesion with submacular bleed there, and he has this dome-like lesion in the temporal upper quadrant, and you can see the OCT there, the typical findings there. We did the FFA and ICG in this patient, but the results were inconclusive because it blocked it, but I don't have the slides for that somehow. But at that time, we had this patient of peripheral CNVM 1 or 2 moving around, so we read this paper by, the Dr. Sraf group and the Dr. The Shield group, and when the terminology of this peripheral exudative hemorrhagic retinochoroidopathy came out, and in this patient, because this was the only seeing eye, we went ahead with the subretinal DG1 cannula TPA injection, and vitrectomy we did, and this is how this patient is doing. In 3 years, he's managing a vision of 6/60, and that lesion, that PED has flattened, and somehow he's managing with this eye. While he was getting treatment in this eye, the other eye was, because that was always a bad eye, we were just watching that eye. See, that eye has also developing lesions, and 1 month back he had this lesions in the left eye which has bled extensively, and this is where we presented this paper to the discussant, Dr. Colin. He wanted FFA and ICG. I could manage his FFA and ICG yesterday, and it clearly shows the BVN and the PCV lesions in the temporal quadrant in this patient, and predicting that probably IPCV resulted in this set of states. Another case, the quick one, this was referred to us as a case of a melanoma there, which somebody has seen this lesion, and I did this ultrasound there, echo, dense, no kappa sign, and there was a bleed there. And this was a doctor's mother. We did give her 1 anti-VEGF, but I think if you go to the literature, it says the extrafoveal lesions, you don't have to do all this. But this patient eventually did well, and after 2 years, and she's carrying on with the PED. And this is my last case, and this gentleman is a diabetic. He had this lesion and this lesion, for which he was given, FFA was done, and he was given targeted laser therapy. You can see the laser spots, and he was following with me after that. And a month back, he had a new lesion which has come up. I could see a polyp, a thumb-like lesion there, and on ICG, the information is not there. And these are my 3 cases of the peripheral exudative hemorrhagic retinal choroidopathy. Thank you so much.
Dr. Tan.
Okay, thank you very much, Dr. Singh, for the very nice presentation and for very nice cases. I'd also like to thank the organizing committee and especially Dr. Vishali for the very kind invitation to speak here. It's my first time at this meeting, and it's been a wonderful meeting. So, yes, so I'll go through a bit of the literature on this. I think we've seen some very nice cases of seeing the spectrum of this, and just a bit of my financial disclosures, none relevant to this presentation. So this condition has been described in a few reports, and I think because it's not so common, it's more commonly been described amongst Caucasians, but we have also seen this in some Asian patients. And they typically present with symptoms typical of retinal diseases such as blurring of vision, floaters, photopsias, metamorphopsias. And the fundus findings are that of an elevated subretinal or sub-RPE hemorrhagic or exudative mass, usually outside the macula. This may occasionally be associated with vitreous hemorrhage, and is most commonly located temporally between the aura serrata and the equator, as shown by some of these images here. Some of the associations that have been described include older age. As I mentioned, there are more reports amongst Caucasians, but I think perhaps this might change as we see this increasingly in our patients. Has been associated with hypertension or anticoagulants, and as you mentioned, age-related macular degeneration or PCV are things that we have to look for. So I think the relevant investigations will be OCT, previously with narrow field of views to look for any central involvement of fovea, but now with the wider angle OCTs, I think this will change, and I'm sure OCT will play an even bigger role in showing the pathology. Ultrasound for the extent of the lesion, or especially very peripheral lesions, and fluorescein angiography and ICG angiography to look for potential AMD or PCV lesions, as we've seen very nicely. I think like the first case, I think, thanks for finding the ICGs. It shows the lesions at the periphery. Yeah. And I was curious also because I saw the peripapillary hemorrhage, and I think that was a bit suspicious, although I don't think that shows up very much on the ICG in this case. And in terms of the differentials, I think these are important things to think about. The choroidal melanomas can sometimes mimic a mass-like lesion, Coats disease, macroaneurysms, choroidal metastases, capillary hemangiomas, and familial exudative vitreoretinopathy as well. In terms of management, I guess it all depends on the etiology. In terms of, we can, in some cases, if it's not affecting vision, we can observe, or we could have laser photocoagulation, PDT, or anti-VEGF, and all of these have been described. But because it's not so common, sometimes we really don't know what's the ideal management. Thank you very much.
Comments from the audience? Yes, Cyrus.
I think Dinesh has now collected a series of about 17 cases, I think.
I think, yeah, we've got more also. Yeah. So my point is, do we have any sort of a treatment algorithm for these? Because we always say the ones in the periphery, we don't need to treat, but sometimes we've seen these patients coming with huge bleeds. And so what now I do is, if it's a one-eyed patient or the other eye has had a large bleed because of PHCR, I give anti-VEGF even if it's not involving the fovea. So I'd like to know the panel's view on this.
I think the superior, yeah.
I've also treated some patients, and we also give an initial anti-VEGF. Yeah. And if the hemorrhage is encroaching near the posterior pole, we go even ahead with the TPA subretinal along with the vitrectomy and fluid gas. And then follow it up with the lavage, and then follow up anti-VEGF therapy, and they do quite well in the long run. Stabilizes the disease.
See, when you talk of PCV, you say you can, if it's extrafoveal, you can laser it. And what is the problem of doing a laser when you have a peripheral?
If there is associated macular edema.
May I just complete?
Yeah.
Now, we talk about possibility of, I'm not talking about whether you do it or not, I'm saying possibility. Now when you know there's a peripheral lesion which has bled once, why should I wait for it to bleed a second time in a bigger way? So for the last 5 years now, not now, but unfortunately not published, every time I see a peripheral PCV lesion, I will delimit the entire area 360 degrees peripheral to it. So that and I will laser the whole thing, so that the entire area where those lesions are right now and where they possibly may develop is lasered and it's completely destroyed. I have not had a single patient who's bled after that, the initial bleed. Most of them were initially the smaller bleeds. If the bleed is bigger, you delimit the bleed further inwards, saving as much as possible of the posterior pole. This is what I've been doing in all my patients.
Raman had a case where he lasered initially and then it was a second time it occurred posterior to the
I didn't laser any case. The first case was already bled. I did vitrectomy with TPA because of the submacular bleed. Second case was I just give one shot of injection. And the last case I told you, it referred from me from outside. Somebody did. I asked him why he was lasered. Somebody found a capillary non-perfusion because he was a diabetic. So he was lasered in that capillary non-perfusion area. He didn't target the lesion there, like what doctor. Yeah.
Yes, sir. Dr. Gopal wanted to comment.
No. If you obviously find a lesion which you can treat, you will treat. But I think we are also considering a condition where there is a hemorrhagic elevation, where you may not be able to find a lesion. Then what do? I don't think delimiting is going to help, because it's not like a rhegmatogenous detachment we are trying to delimit. The whole lesion has to be frozen, if at all. Yes. If at all you want to destroy the lesion which is within the hemorrhagic mass, and if you don't want to operate, best is to freeze the whole thing. That will work better. In fact, almost 25 years back when Professor Alan Bird visited Shankar Nethralaya and we showed him that kind of a case, that was a suggestion he has given us. So you want to destroy the polyp which is inside, which you can't even identify now, because it's all covered by hemorrhage. Your ICG was not there, of course, those days. And best is to freeze the whole thing. The whole thing may become a scar, but at least you save the periphery,
so
the posterior pole.
Dr. Lingam, I have a question. Can you give an anti-VEGF and then do a cry also?
You do both, I suppose.
Yeah.
Not in such a highly elevated mass. I guess where you can treat with a simple laser, you obviously will do it if it's a flat lesion.
Exudation there as well. When you're looking at this kind of, you need to be thinking about something. This is another patient who's got a much more marked phenotype of the same disease. So you can see multiple of these lesions, kind of, pigmented lesions, kind of orangish in color throughout the posterior pole. And again, kind of, if you magnify them up, you can see that these are these pigmented lesions kind of that you can see through the posterior pole. Is the same disease, but it's varying phenotype. So it doesn't have to look like a book picture all the time. The first picture actually is the same disease. And when you do a fluorescein angiogram, it starts getting typical, and this is where pattern recognition becomes very, very important for this disease. The disease name is already there in the brochure, so you know what I'm talking about. What we see is these areas of hypofluorescence and hyperfluorescence. And what you see is the absence of inflammation. So there's no inflammation. This is not inflammatory disease. This is not like a choroiditis or a multifocal choroiditis. There's no inflammation, no hot disc, blood vessels are fine. But you're seeing this kind of hypofluorescence areas and hyperfluorescence areas. And when you look at the more typical disease, then you see this much more kind of markedly, where you see this typical pattern that you're seeing, where you're seeing hyperfluorescence in the areas which are looking pale on the color fundus photograph, and kind of hypofluorescence in the other areas. And you also see these kind of white dots, which Larry Newsy says is necrosis happening in those areas. I'm not sure whether that's been proved histologically. Jose Pulido will let us know. And this is the autofluorescence, and this is where the name of the disease comes from. But this is, again, very, very typical. So it's the inverse of the fluorescein angiogram. What we're seeing as hyper is not hypo on the autofluorescence, because there's a loss of RPE there. So there's loss of RPE there leading to this loss of kind of fluorescence. And in intervening areas, you're getting a hyperfluorescent area. So again, when you look at kind of, the OCT, what you see is these areas of RPE loss. There's subretinal fluid, exudative detachments, and this clumping of RPE. So there's RPE loss there. On the bottom, you can see the clumping up. And this is, again, more typical, a lot of fluid there, loss of RPE, and kind of, clumping of the RPE. And so last slide, my time is up. So, oops, just one more.
So when you see the giraffe pattern on multimodal imaging, think of B dump. That's what we have to say about the disease. So if you remember that pattern, hopefully you'll save someone's life. Because as Dr. Jose Pulido will tell us, a lot of these people don't have their cancers diagnosed before we diagnose the disease.
Great.
Thank you very much.
Superb discussion there. So I'm going to talk about a little bit more. I had 50 slides, but I had to trim it down. So Machamer first described this, and he described it as being relentless. And we just heard about many of the findings in the posterior pole, but there's a few other findings that I want you to realize. These patients can develop these bluish lesions elsewhere in the body, and this is because there's rests of dermal melanocytes that are also proliferating, and it's been thought in the past to be metastases. It's not. It's benign dermal melanocytes that are proliferating, because these dermal melanocytes are very similar to uveal melanocytes. Something that David Saraf taught me was that these patients also get cysts in the ciliary body because of dysfunction of the ciliary body, because of the proliferation of the melanocytes throughout the uvea. And a few years ago, we had a hypothesis that there was a factor in the plasma that could be removed that caused B dump. And this is one of our patients, and this is a milder case. And here's a case similar to the ones that were just presented. So we did plasma exchange, and these patients did better, and it's now a way of treating these patients, so it's not relentless anymore. And we then took cultured melanocytes and had different controls. So this is normal growth of cultured melanocytes. And then if you put the serum of one of these patients with B dump on it, you can see the exuberant growth. This is another control. This is yet another control. This is yet another control. And then this is the second case, and you can see the exuberant growth. So it was a factor, and we called it CMEP, cultured melanocyte elongation and proliferation factor. And we were able to show that if you put it through a protein G column, you took out the active component. So it's an immunoglobulin. There is a factor, it's in the IgG fraction. You can do plasma exchange and help these patients. There was a recent article by the Adamus group in Oregon, and they said that this CMEP factor is actually related to hepatocyte growth factor. The problem with the paper is they don't show the science behind it. And how can you get elevated HGF levels and elevated hepatocyte growth factor antibodies at the same time with the CMEP? So more data has to be worked out to see what the CMEP factor really is. Thank you.
Thank you, Dr. Pulido. Any comments, questions from the audience? I think we move on to the next case, indirect lightning maculopathy by Dr. Dhananjay. Yes, sir, please.
I would like to ask you a question. There was one patient of ours in Singapore, which was seen by Dr. Arun Singh also, was suspected to be B dump, but it's only involved in the anterior segment. There was a lot of proliferation from the iris and ciliary body, which actually ultimately penetrated through the thinned out sclera in the limbus and started to bulge as subconjunctival brownish masses. And it was not non-malignant, definitely, but it was diagnosed as B dump by many specialists from all over the world, because she has been under follow-up for almost 10-15 years, but no posterior segment problem. She has 6/6 vision, retina is normal, no RPE changes. Is it possible that it's isolated to the anterior segment?
Yeah, so I don't think so, because this is a diffuse problem. The CMEP is circulating everywhere. I have seen asymmetry where one eye is first and the other eye is very subtle, but you should see fundus changes, so I don't think that's the case.
Thank you, sir. Dhananjay?
Discussant is Dilraj.
I thank the organizer, especially Dr. Vishali, for having me here. I'm talking about a lightning maculopathy. Now, we all know about the lightning strike and how it hurts the body very severely. But this is a case which is different because it was an indirect lightning strike. So, the story of a 40-year-old healthy man who reported a blurring of vision in both eyes for about 10 days after watching a lightning strike the ground about just a couple of meters away, and he watched it from his house through an open window. So at this point, it's important to note that he was not touching any electronic device. He was not holding any phone or talking on a phone. He was not on any other electronic device like a computer. He was away from the window frame or the panes, so not touching even the wall. And what happened to him is immediately saw a yellow spot, which was probably an after image, and had a visual decline after a day. So when he presented to us, he had visual acuity was 20/70 and N10 both eyes. His color vision, contrast sensitivity, and visual fields were unaffected, and his NTS segment, LEDs and Dinesh were also unremarkable. It's also important to note that he had no history of smoking, any sun gazing or exposure to a sun or a solar eclipse or a welding arc. So this history is important in view of this imaging, because these images look like the images of an eclipse retinopathy, where you have a faint yellow spot if you see in the top two pictures. I'm sorry. You can see the faint yellow spot in both the eyes. On OCTC, the hyperreflective echos and the disruption of the ellipsoid zone. And this hyperreflective echos actually take a triangular shape here. And fundus autofluorescence is also interesting. The central hypo signal is actually accentuated and darker, whereas the parafoveal hypoautofluorescence is actually attenuated. By the follow-up of 12 months in which we did nothing, just observed the case, his fundus picture as well as the autofluorescence normalized. So this is the normal pattern restored. But the gap in the EZ, the ellipsoid zone, persisted in both eyes in spite of recovery of the near normal visual acuity. So the reason for presenting this case is when you have a typical or direct lightning strike which hits the body either directly by the lightning hitting the person directly or traveling through the ground. So it causes generally burns on the body, on the eyes, as well as in the macula because of the resistance of the heat, and which results in this kind of more prominent change both acutely and late. Thank you.
Dil.
Thank you, Dr. Shukla. That was a great case. And I just wanted to take us back a little bit when Dr. Jaffe described lightning maculopathy in the pre-OCT era. And you had commented on noting faint yellow spot in the macula when the patient presented. And then that was exactly what was noted about 24 years ago. At that point, we're not sure whether this is a full thickness macular hole or is it a cystic change in the macula like you showed on your OCT with a thin foveal tissue that was draping over the macula. So we have recognized that lightning injuries can either be thermal, which often are with direct contact with lightning, or an indirect lightning injury like you described, which is primarily from the phototoxic injury. More recently, we are aware of laser pointer injuries because there is increased availability of high power unregulated laser pointers which have a wavelength and power that is outside the limits of what is recommended by the regulatory authorities. And these laser pointer injuries are also very characteristic because unlike solar retinopathy or lightning maculopathy, when you have foveal damage, there's often a linear dendritic appearance around the fovea or anywhere in the macula, and that's either attributed to movements of the laser or microsaccadic movements of the eye as it focuses on the laser beam. Similar to the lightning injury that you mentioned, laser pointer maculopathy also has a potential for recovery. It depends on the severity of damage to the outer retinal tissue. There's definitely a role of fundus autofluorescence to monitor, but it depends on whether or not the retinal pigment epithelium is affected. You had mentioned there was no history of exposure to welding light, and that's because welder maculopathy is another entity that is recognized when there is, again, outer retinal damage, such as focal ellipsoid zone loss, which may or may not be reversible, and that determines the visual potential. With the recent solar eclipse, total eclipse in North America, there was a lot of interest on solar maculopathy, And this was a group from New York Eye and Ear that described acute changes right after solar retinopathy using adaptive optics and microperimetry. And you'll note on the OCT that there's a very similar kind of an eruptive appearance of this hyperpigmented area that comes out through the outer retina. There have been reports of people using high-dose steroids in the acute phase to try to reduce some of these changes, but there's absolutely no evidence that that works. But again, I would like to congratulate you on a very nicely presented case that distinguishes between the direct thermal and phototoxic injury versus the indirect just phototoxic injury. Thank you.
I think you referred to a few papers where they have shown a lot of injuries from the laser which they throw up in these concerts. And a lot of concerts, I think there is a large series from Germany as well as Fernando's group, that because of the concert, they have these laser lights just going around and they are not regulated, and there's a lot of people having visual problems after the concert.
Not only that, there have been also reports of airplanes when they're landing at airports, the people standing can actually shine laser pointer lights at pilots and severely distract them. So this is definitely a concern because they are available unregulated over the internet.
Anything particular about the wavelength of the laser pointer which is the safest?
So there are different guidelines as to what class of lasers are considered safe. And I don't think it's as much of a wavelength issue with these as it's the power, because you can get small 100 milliwatt lasers that are
These
portable.
are just 2% or something.
Dilraj, I would like to dissent because wavelength is an issue. Normally we use red pointer for a reason because they are more penetrating but they are less toxic. If you use a blue light, a blue laser pointer, it is supposed to be, it damages the fovea more. It is more absorbed by the foveal pigment. So, and the other thing is about the this power rise by the laser. They cause only 5 degree rise in temperature. So normally looking at laser pointer also should not cause any damage. But when you keep looking at it for some time, which happens, as you said, in a discotheque where people are also sometimes on drugs like poppers, so with which accentuate the damage, and in fact they mimic the damage caused by photic retinopathy.
Yeah, so the message is don't go to discos. So we have the, thank you, Dilraj.
Yes. Just, this is really interesting, and I'm just worried that people are going to, and you did a great job separating out indirect lightning maculopathy from direct lightning maculopathy. But I wonder whether this looks so much like laser that whether one could call it plasma light maculopathy, right? Because lightning is basically a plasma. And so the person was looking at this plasma light and developed a maculopathy similar to laser damage.
Yes, actually the answer to this is a little more convoluted. Actually, there are 3 types of phototoxic damage actually. So you can have a very high grade laser like lightning, or a very high grade burn, and like an industrial laser accidents. So we use this therapeutically NDA capsulotomy. So that's the plasma for you. So that causes a burn or a hole actually. Then there is something what you pointed, the laser light. It's a photocoagulated type of injury, or the photo burn. It raises the temperature more slowly, but to about 10 to 20 degrees centigrade. And then this is the third type of injury, which is a phototoxic injury, which is actually generally very subacute and generally not noted. Thank you.
Right, thanks, Ramesh. Thanks, Dilraj. We go on to the second last talk on diffuse peripapillary choroidal excavation with PCV by Pukhraj Rishi, and the discussant is Dr. Bailey.
May or may not be reversible, and that determines the visual potential. With the recent solar eclipse, total eclipse in North America, there was a lot of interest on solar maculopathy, and this was a group from New York Eye and Ear that described acute changes right after solar retinopathy using adaptive optics and microperimetry. And you'll note on the OCT that there's a very similar kind of an eruptive appearance of this hyperpigmented area that comes out through the outer retina. There have been reports of people using high-dose steroids in the acute phase to try to reduce some of these changes, but there's absolutely no evidence that that works. But again, I would like to congratulate you on a very nicely presented case that distinguishes between the direct thermal and phototoxic injury versus the indirect just phototoxic injury. Thank you.
think you referred to a few papers where they have shown a lot of injuries from the laser which they throw up in these concerts. And a lot of concerts, I think there is a large series from Germany as well as Fernando's group, that because of the concert, they have these laser lights just going around and they are not regulated, and there's a lot of people having visual problems after the concert.
Not only that, there have been also reports of airplanes when they're landing at airports, the people standing can actually shine laser pointer lights at pilots and severely distract them. So this is definitely a concern because they are available unregulated over the internet.
Anything particular about the wavelength of the laser pointer which is the safest?
So there are different guidelines as to what class of lasers are considered safe. And I don't think it's as much of a wavelength issue with these as it's the power, because you can get small 100 milliwatt lasers that are
These
portable.
are just 2% or so.
Dilraj, I would like to dissent because wavelength is an issue. Normally we use red pointer for a reason because they are more penetrating, but they are less toxic. If you use a blue light, a blue laser pointer, it is supposed to be, it damages the fovea more. It is more absorbed by the foveal pigment. So, and the other thing is about the this power rise by the laser. They cause only 5 degree rise in temperature. So normally looking at laser pointer also should not cause any damage. But when you keep looking at it for some time, which happens, as you said, in a discotheque where people are also sometimes on drugs like poppers, so with which accentuate the damage, and in fact they mimic the damage caused by photic retinal.
Yeah, so the message is don't go to discos. So we have the, thank you, Dilraj.
Yes. Just, this is really interesting, and I'm just worried that people are going to, and you did a great job separating out indirect lightning maculopathy from direct lightning maculopathy. But I wonder whether this looks so much like laser that whether one could call it plasma light maculopathy, right? Because lightning is basically a plasma. And so the person was looking at this plasma light and developed a maculopathy similar to laser damage.
Yes, actually the answer to this is a little more convoluted actually. There are 3 types of phototoxic damage actually. So you can have a very high grade laser like lightning or a very high grade burn, and like an industrial laser accidents. So we use this therapeutically Nd:YAG capsulotomy, so that's the plasma for you. So that causes a burn or a hole actually. Then there is something what you pointed, the laser light. It is a photocoagulated type of injury or the photo burn. It raises the temperature more slowly, but to about 10 to 20 degrees centigrade. And then this is the third type of injury, which is a phototoxic injury, which is actually generally very subacute and generally not noted. Thank you.
Right, thanks, Dinesh. Thanks, Dilraj. We go on to the second last talk on diffuse peripapillary choroidal excavation with PCV by Pukhraj Rishi, and the discussant is Dr. Bailey.
There's a case of diffuse peripapillary choroidal excavation in a 27-year-old Asian Indian lady who presented with gradual, progressive, painless diminution of vision in the right eye since the last 3 years. So she was clear she did not have any history of trauma, and her past medical history was unremarkable. Systemic examination was unremarkable, and her best corrected visual acuity was 20/60, which was about 618, and the left eye was essentially normal. And this is how the fundus looked. Here you can notice this area of RP choroidal atrophy and another watermark area further temporal involving the fovea. So we did a fluorescein which showed this area of staining and progressively increasing focal hyperfluorescence just next to the disc. So this is, I think the same, yeah. So this is the OCT, and it's passing through that choroidal lesion next to the disc, as seen here, and the fluid is involving the fovea. There are some cystoid changes in the retina, and you can see there is a gross choroidal atrophy, but there is some amount of Brooks membrane going into that area. So this is the vertical scan, and you can notice this area of choroidal knuckle-like lesion standing out, and this is the macula. This is the OCT angio passing through the knuckle-like lesion, which is hypo within, and there is a capillary hyperreflectivity around that lesion, and with a flow deficit within. So this is a young adult female with a reasonably preserved visual acuity and photoreceptors despite the subretinal fluid, presumably since 3 years, with no prior history of trauma. So the question is this a sequelae of a choroidal hemorrhage occurring due to PCV, noting the aneurysmal or the polypoidal lesion next to the disc. So I would also like to show this. Yeah. So I'd like to seek the opinion of Dr. Freund and others.
Let's see if we could switch to my slides, please. So, Dr. Rishi, thanks for picking such an easy case. I'm just joking. This is, I think, a very difficult case, and I don't know precisely what it is. There's some very unusual imaging findings. I agree that there's peripapillary aneurysmal type 1 or polypoidal neovascularization. There's this very large defect that to me looks like it involves the RPE, probably Brooks membrane, and there's also a lot of loss of choroidal tissue as well. You could call that some form of focal choroidal excavation. But there's also a relatively preserved outer retina. So the idea that this was all caused by a large subretinal hemorrhage, that's a bit difficult for me to accept because there's no fibrosis. There's really not other I mean, I've never seen hemorrhage clear in such, certainly aneurysmal type 1, you can have hemorrhage clear, looks pretty good. But I haven't seen hemorrhage clear, completely destroy the RP Brooks membrane and choroid, and do that little damage to the retina and not leave fibrosis. So I was confused about this, and when I don't know the answer, I turn to my smart friends, and so I asked Vasada, and that was his response. That wasn't too helpful. And then I asked David Seraf what his response was. That was his, so that didn't help me. So when you're really stuck at a case conference, the person to go to is Jose Polito because he will come up with something that just you haven't thought of. And so I don't want to take credit for this, but so this was his suggestion. Did I consider that maybe this is a decalcified choroidal osteoma? And in order to become a little more comfortable with that diagnosis, I looked at some of my own cases, but also in the literature and this reference that he pointed me to. So here's one of my patients. It's a healthy male, similar age to your patient, and that's the osteoma showing the shadowing of the bone. The reason I'm showing this one is because it shows that you can clearly get excavations in osteoma. That's been reported. Usually that's in association with CNV, but Adrian Fung, I think, had just one in JAMA Ophthalmology showing excavation without CNV, and this is just a nice swept source images. We don't see the osteoma here, but they can become decalcified. Here's a 40-year-old male from this publication that came out of the Milan group with Francesco Bandella. And here's, you see a bigger excavation, not quite like Dr. Rishi's case, but in that same publication, there's this case. And this one looks, at least in the PM bundle, it has a lot of features that are similar. There's still part of it that's not decalcified, but in the decalcified area, it looks rather similar to me. So here's a comparison between your case and then the case of a patient, similar age, female, and to me that seems that's the best idea that I can come up with, so I have to give credit for Jose. So I suggest that maybe the diagnosis here is a decalcified osteoma associated with secondary neovascularization and aneurysm that formed aneurysm. So, but it could be something
but
else.
So what would you tell the patient? Would you treat her going by the persistent subfoveal fluid?
I don't know. I think one of the problems is when you, in some of these situations where you have subretinal fluid and the retina, outer retina looks okay, sometimes you get rid of the fluid and the retina falls onto nothing, and then you sometimes lose photoreceptors. So I'm not sure if getting rid of that fluid would definitely lead to a better. I might just watch this for a while. It may have been there for a long time. Maybe the fluid will start to go. I wouldn't be too aggressive until there seems to be a need that you've documented things getting worse.
But there was a small difference between the two. In Rishi's case, there was nothing pushing from below. And the other one, I think it was sort of elevated. If you go back to your slides and see it, the last one.
Can we put my slides back? Yeah, I'm not saying that this is a perfect match, and you'd have to say that in Dr. Rishi's case, that it's completely decalcified, because we don't really see the osteoma. But I think the image on the right shows that when osteomas resolve, they can look similar. But yeah, without knowing the history, who knows? But it's hard for me to imagine that this was due to some very severe inflammatory event or hemorrhagic event and could have done such little damage to the retina. To me, that suggests maybe more of an insidious process, but honestly, I don't know.
Dhananjay?
Sir, could I suggest one more differential diagnosis for this? Could it be an occult optic pit with the resolved schisis resulting in the RP degeneration?
How would you then explain, well, what happened to the choroid? That's, I mean, optic pits, you can definitely get fluid that goes intraretinal, although when you get the subretinal fluid, it's usually because it's broken through the outer retina, so you have an outer retinal hole. Here, there's no real findings that suggest an optic pit. We can see most of the nerve on the fluorescein. I cropped that. So to me, the findings wouldn't associate. You typically don't see aneurysmal type 1 or with optic pit. So, thank you. Yes.
Technically, would Dr. Rishi's case qualify as an excavation, choroidal excavation?
Well,
just technical question. OCT-wise.
I mean, excavation is whatever you want to call it. It's not like we have ground truth histopathology. So, but it's well documented that osteomas can develop focal choroidal excavations. Usually you don't have such profound loss of the RPE, and so that's what's atypical here. But often in more advanced osteomas, those overlying layers do completely sort of degenerate, and you can get very atrophic things. You can get CMV. So basically, it destroys the choroid. If you want to call that an excavation because it's excavated, sure, why not?
Thank you. It's 5:50 and we are right on time. Last case, incontinentia pigmenti, presented by Dr. Shubina and to be discussed by Dr. Jose.
At the outset, I would like to thank the organizers and Dr. Vishali for having me in this colorful world of Jaipur. My case is incontinentia pigmenti, PEEP into retinal vasculature. The slides are not moving. A baby with post-conceptual age of 40 weeks was referred to us for ROP screening. The period of gestation was 37 weeks and birth weight was 2,000 grams. He had had stormy neonatal course, history of seizures and apnea was there, and vesico-bular skin lesions were there on the trunk, the sides of the trunk, both the limbs, the face was spared. Anterior segment was unremarkable. On posterior segment, what we were having was dilated tortuous vessels. Then there's avascular periphery on both the sides, arteriovenous anastomotic channels, shunts were there, plus there's hemorrhages and rot spots in the left eye. Just a closer look at that. In the right eye, we could pick up some areas of neovascularization superior-temporally. In the left eye, we are having neovascularization inferior-nasally. So we have a term baby with peripheral avascular retina with dilated tortuous vessels, arteriovenous shunt vessels, neovascularization with skin lesions, and history of seizures, and no positive family history. Patient was labeled as a case of incontinentia pigmentae because he was fulfilling 1 major and 2 minor criteria. We asked for fluorescein angiography for the patient under topical anesthesia, which we do by red cam clarity. What do you do? There's a video, okay. This is the fluorescein angiography. It shows grossly capillary non-perfusion in the periphery. These capillary plexus juxtapapillary is getting filled. Then there are arteriovenous anastomotic channels. Similar is the condition in the left eye. This is the right eye, and the left eye also rot spots. These big venous loops are seen. So what we have is something like this. In the right eye, there seems to be disc neovascularization as well as neovascularization superior-temporally. And this is what we have in the left eye, arteriovenous shunts. These are the radial capillary plexus, peripapillary plexus looks like that, and arteriovenous shunts. So we went ahead with peripheral laser photocoagulation. We, in fact, were slightly we were not very aggressive about it because the macula had not developed, and we know that in incontinentia pigmentae, the retina, it develops normally. The patient comes back to us, he develops this, the ridge is present just beyond this. We went ahead with more laser in both the eyes. The patient gets vitreous hemorrhage and pre-retinal bleed in the right eye, just 1 week post-laser. In the left eye, however, we could laser more when the patient has come back. We thought that if this vitreous hemorrhage does not resolve, we are going to go ahead with the we are going to go ahead with the vitrectomy treatment. Patient comes back for vitrectomy, but he already has retinal detachment and vitreous hemorrhage. The patient was taken up for vitrectomy, but due to dysplastic retina, we did not achieve much success in this. We were more aggressive for laser in the left eye. If we see, the vessels also have developed. This is what he was earlier. This is after laser treatment. The vessels have started growing. They have gone beyond what they were earlier.
Time is up.
And the last slide, that's it.
Yes, Dr. Jose.
Thank you. These have been great cases today. And I think that the diagnosis is incontinentia pigmentae. As you know, it's an X-linked dominant disease, so that it's lethal in males. There have been a few males reported in the literature. They are either XXY or have somatic mutations that allow them to survive with this. Now, a couple of things about it. There's no family history, but remember the vesicular lesions tend to get better over time, so that when you see the mother, she won't have it, but she'll have some funny teeth. And if you do a wide field fluorescein, you will see some changes in the periphery. Oh, good, you're not counting this to my time. This is good. And the retinal vasculature is incredibly well regulated. It grows in waves according to the need of the inner retina. It's auto-regulated by the needs of the inner retina, and it's sensitive to many factors, as you well know, radiation, metabolic diseases, et cetera. Here's cases of West Nile retinopathy, vancomycin that's associated with it. Systemic diseases are associated with retinal vascular complications. Well known are embolic diseases, hematologic diseases, the classic is sickle cell, and incontinentia pigmenti. Newer diseases that are associated with vascular complications, von Hippel-Lindau, we've recently shown that they can get peripheral non-perfusion and leakage from the vessels, and 2 papers will be coming out very shortly. The groups from Italy and Bailey-Freund have shown that with neurofibromatosis, this affects the retinal vessels as well. So this is something that you need to know about. Dyskeratosis congenita is loss of telomerase, and because the telomeres are important to keep the cells viable, they die. So what is going on with incontinentia pigmenti? Well, the pathophysiology is now being elucidated for incontinentia pigmenti. It's NEMO. NEMO stands for NF-kappa beta essential modulator, and its official name is IKK gamma. It's found a little bit in the retina, but a lot in the endothelial cells. So here you can see how much expression there is in the retina, but here you can see how much more expression there is in endothelial cells. So this is an endotheliopathy, not a retinopathy. And the way that NEMO works in this case, NEMO is very, very important. Tomorrow, I might actually be talking about it in terms of vitreoretinal lymphoma. But in this case, what happens with NEMO over here is that once it's activated, it goes forward to allow survival of the endothelial cells. So if you don't have NEMO, NEMO's out, the cells die. And that's what's going on in these endothelial cells. So with that, I'm done, and it's thank you very much for letting me be here and present.
Thank you. So I think we come to the end of Rishi 3.
Really some thank you. So we're really grateful to Pavan Shori, Rajkumar Sharma, and Vishal Agarwal. I mean, this is a lot of work to put this type of a meeting together. And obviously, great thanks to my colleague in Vishali for all of her work in arranging this program. We're also very grateful to all of the speakers today. Many of you traveled large distances, and all of the excellent audience participation. I hope you enjoyed the meeting like I did, and we look forward to Rishi 2020.